Hi, everyone. Good evening. Welcome to our soft landing fly high in your clinicals evening. I would start with apologies first, because this had been together at a very short notice, primarily because quite a few of us were busy with our ARCPs and grid applications, and also the clinical exam pattern kept changing with time, and maybe some of us were not very familiar with the virtual format. But we thought this is something that's we do worry about a lot, and we have all gone through this. So it would be really unfair if we don't discuss bits on the clinical exam. So we've just put it together at very short notice, and we'll try to keep it very focused and touch on some top tips so that you all are prepared for the exams. So I started with this slide. Obviously, if someone, so I'm Neelakshi, I'm one of the sorry, I should have introduced myself. I'm Neelakshi. I'm one of the soft landing team members, and I'm currently an ST4 trainee at the Prince Royal University Hospital. And as I said, if someone showed me this slide the day before my exam or 4 weeks before my exam, I would have been very cross with that person, because the last thing I was able to do before my exam was keeping calm. But yeah, we have to do this. We have to try and keep calm, and then we'll be able to fly high in our clinicals. This is something I believe in whenever I find it really difficult, and whenever I think I have got a big obstacle ahead. I always look back and try and see how far I have come. So you all have come a long way. This is not the first exam you're taking, and I'm sure you've taken even more difficult exams before, starting from entrance exam to medical school. Some of you have done your post-graduation back at home, and then maybe some of you have already taken the PLAB exam to get the licensing. So I know it's very easy for me to say this is just another exam, but trust me, it is just another exam. And if you are completely blanked out and you don't know what to do, I would say, and this is what I always go back to, is looking at the materials that are there on the RCPCH webpage. It gives you an overview of what is expected. I think that's the most important thing we need to know, especially if we are not familiar with this format of exam. I've just read it, reread it, and still keep reading it. Because obviously they keep changing it every 6 months because of the virtual format. And then I think it has got a lot of information. It has got even scenarios that you can use as an example, and gives you an idea what to expect. And obviously RCPCH says this always: the aim of the exam is to assess whether the candidate has reached the standard in clinical skills expected of a newly appointed ST4. I think some of you are, if you're working as registrars, then you already know what they're trying to look for. And if you're working at a junior level, try and think through the extra questions that your registrar went back and asked on your history taking, or the extra clinical skill he or she picked up, and try and get those embedded into you, shadow your registrar. I think that's the best way to know what is expected of a newly appointed ST4. And if you look at the areas that they would want to assess you on, this is something you do every day, and you demonstrate professional behavior every minute of your practice. So I am sure it's just try to think of it. I know someone will be watching you, which is the difficult bit, but try to think of it as if it's just another patient you're seeing in CDU or in the ED or on the ward, and it's just another parent you're speaking to, and try and just get into those shoes before the exam. Obviously, we are very short on time. We have 2 hours and very tight. And I would just quickly talk through how the evening looks like. We are very fortunate, even at a short notice, we are very fortunate to have Dr. Pramod Vallabhaneni with us. And as you know, he's one of the consultant mentors for the soft landing project. He's a consultant pediatrician at the Swansea Bay University Hospital. He had been with us in quite a few of our previous workshops, and he has very kindly agreed to be with us this evening and talk us through some of his top takes for history taking. And of course, he'll be around for our communication mocks as well, and he'll be around for questions. I think he would be the best person, if you have any queries, best person to speak to and clear them up. And then we'll have a short presentation by one of our teams of landing members, Bola, who will talk through some of her top tips for the virtual exam. We'll aim to take a 10-minute break, but we might just run into the break, and we will be around during the break if I have any questions. And our aim is to have 1 hour of communication practice. And I would say we might not be able to have every one of you practice during this hour, but volunteer, obviously, volunteer yourself first. That's the way to make sure you at least get one practice scenarios. And as I said, we'll be around, so we'll talk through some of the other scenarios which we won't be able to practice. So I think without wasting much time, I'll hand over to Dr. Pramod. Let's see. Dr. Pramod, are you? Yes, thank you.
Can you see my slides?
Yes, we can.
Yeah, thank you. One second. Right, thank you. Neelakshi, thanks for the invite and thank you for having me this evening. There's something I want to tell you about teaching and me. If somebody asks me to teach, I always find it difficult to say no, because I love teaching and I will show up anyway if you want me to teach. It's just that I think, I hope people don't get bored. But can I say thank you to Team Soft Landing again? I did the interview talk, and since then my evenings haven't been the same. It's been such a great privilege to meet trainees all across the UK, and I believe it's a great opportunity, and yeah, just to practice with them. And thank you for asking me to speak about history taking. The thing about virtual MRCPCH, and if you're a trainee, you're here this evening and you want to make the most out of it. Can I tell you something about the virtual exam? The exam has been designed with such simplicity that this is your best shot to pass your exam. There are no two ways about it. And let me convince you why. Because there is no trickery when we are writing the stations. And if you look at some of the example stations, you speak to some of the people who've given the exam, if at all they've had failure, it is because they've got the station completely wrong. So my first advice to you going forward today is, if you don't observe what you're going to do, if you don't know the circuit, you don't know what is expected out of you, then I think this exam might seem difficult, but this is your best chance to do it. This morning I was coaching my son's football team, and you see, when you're on the touchline, you can always see how the opposite team is scoring the goal. And you shout out and you tell them, okay, this is what you got to do. But with your exam, and sometimes I felt this as an examiner, you want to tell the trainee, no, you got it wrong, and you can help, you can prompt. But if you don't observe those details yourself, I think it becomes really hard. And if you really want to focus on one thing for the exam, and I want you to remember something about situational awareness. I just want to show you a very quick clip. This is a young daughter of a father who's given him an iPad. Okay, so she gives him an iPad for Christmas, and let's see if technology works. And Neelakshi, will you give me a thumbs up if you can hear the audio on this video? Yep. Yep. He didn't know what to do with the iPad. He thought he could use it as a chopping board. Sometimes in the exam, if you really don't read the question and you don't know what to do, I think you're navigating it right down a different environment. In terms of the whole task, you got it completely wrong. So on the day of the exam, especially with your history taking station, but also if you look at this slide, you can't control, for example, the environmental factors. You can only prepare so much for it. For example, you'll have your laptop, you'll have your Wi-Fi, those all things you can control. But if you really want to have your performance at a top level on the day of the exam, you got to control your effects and behaviors. What do I mean by that? what do you do if you have a bad station? What do you do if one of the stations wasn't really optimal? And how do you keep maintaining that performance for those 90 minutes when you do the exam? That comes with practice. Your performance gets scaled to a higher level and a higher level with practice. And you must be thinking, okay, you're talking virtual exam. How do I practice for this virtual exam? It's not I'm going on the ward or examining patients. But I tell you, this is your best bet to pass the exam because you got to deliver a script. It is as simple as that. If you know your script of what you need to deliver, be it history, which you're going to talk about today, or let it be a clinical examination, you are bound to pass the exam. And if you look at the scoring grid for the exam, there is a very clear instruction to the examiner on what they should do. And if you follow your script and it aligns with what is expected, you will see you'll pass. And actually, the grid is on the Royal College website. It gives you what is expected, and Neelakshi, pointed to that in her presentation earlier, that the Royal College document is actually very clear of what is expected of you. So in terms of why do I focus on situational awareness? I see a lot of trainees get flustered when the exam is ahead of you. And if you can't deliver your peak performance for whatever reason, if you can self-assess, you can read your own, performance is not going well, or there's something that you're not too sure, I want you to drop down into a survival zone. Don't give up on that station. Get yourself to a bare fail if it has to be a fail, but don't have a clear fail because that pushes your decile or your scoring the other way. So please focus a little bit on your situational awareness and get some tactics in your own mind of what you're going to do, because that, you can coach somebody about situational awareness, but you have to prepare for it. So in case you're wondering, hang on, this guy was going to talk about pediatric history and he has so far not mentioned one word about pediatric history. I am getting there. I just want to tell you the importance, and I don't know if you heard this equation at any point in your medical school careers. So this stands for reading the blinking question is half the battle won. Okay, you can substitute the B with other words if you want, but this is so important for your exam. Roughly, actually, let me see if you know this. How many minutes do you get to read your station before you start? Put it in the chat section. How many minutes do you get to read your question? Very good, Yasmin, well done. And whoever is now putting the answers in, good. So what do you do when you read the question? So now you got to start thinking, okay, I've read it once, don't be too overconfident, but read it again. Okay, once you've read it twice, you want to do this on Practique. It's okay, in your mind to start thinking, okay, this is how I'm going to approach the station. If you want to write down some stuff, people are worried about writing anything down on this, virtual exam. So if you don't want to write it, you just, have this checklist in your mind. And checklists are what is going to get you through your virtual exam. And I'm going to share something today which might help your history taking station. And if any of you are Star Wars fans, I will show you a picture, and I'm just trying to build your interest in giving me that answer. My first tip for you is give yourself 30 to 45 seconds in any station to do the pleasantries, to do what you would in a real life scenario. For example, you are telling the examiner, I'm going to introduce myself, I'm going to look around, I'm going to say hello to the child, I'm going to play with the child, because those are all important things. That's how you're building rapport. You can't do it virtually in terms of seeing the patient, but you've got to be explicit and say. Why do you need to do that? I think it controls your heart rate. You will agree with me, if you control your heart rate, most things become very easy. You control your heart rate, less stress, less cortisol, your mind starts thinking better. I prompted you earlier about Star Wars. Tell me, who's this character in Star Wars, team? Anybody in the chat? Who's this? Well done, Christina. Very good. So R2-D2, okay? Again, if you're wondering, hang on, this guy is talking nonsense so far. He has told us nothing important about pediatric history. But let me tell you all, if I start telling you, like a medical student, this is how you take a pediatric history, you will find it highly, insulting. I appreciate each of you has got a core element of how to take a pediatric history. You do it day in, day out. That's your second nature. You are kings and queens of taking a pediatric history. Now, why on earth I'm showing you a picture of R2D2? The problem I find in membership exams is trainees have this huge canvas in their mind about a pediatric history. You're not targeted, you're not focused. This exam needs a razor sharp approach to pediatric history taking. No waffle, no blah. To the point, ask the question, get the answer, move on. So what do I mean by that? So I am going to share a model, and I don't want to play that video because I know the time is short today. Instead of R2D2, I'm giving each of you the force to conquer pediatric history. That is R7, C4, G8, C9. What are these? I will build up on it. And forgive me because I'm going to rush this presentation slightly because of our timeline this evening. But if any of you want me to expand on it on a later date, I'm very happy to come back and do it. I believe in an exam, if you know these formulas, you will get a clear pass for a history taking station because nobody can fail you. Why? Because you've asked every question that you need to ask. Now, let me build up on this. So when you're doing your history of presenting complaint, they've given you a scenario. You know the station is going to be respiratory, cardiovascular, GI, CNS, musculoskeletal. Let it be any of those stations. You all are master historians, but here in the exam, you got a clock which is ticking. So you have to fine tune your history to meet that clock. And how do you do it? Give yourself, 10, 20 seconds for this question that I have on my screen. I use brain dumps because brain dumps are useful. If you know already what's in your mind, I think if anybody tells or adds something, it gets better for the next time. So why am I asking you to list 7 key respiratory symptoms? Give yourself 10, 15 seconds, put it in the chat if you wish to, but if you have a pen and paper, work it out for yourself. You can argue with me, hang on, Pramod, there are hundreds of respiratory symptoms, but I've got news for you this evening. There are only 7 key respiratory symptoms for a pediatric exam. You ask those 7 questions, you got your diagnosis. How? I will prove it to you. And I know some of you are putting the answers in the chat. But the question is, you see, could you recall 7 as quickly as you wanted to? Now we think, okay, and we think, and you're thinking. So the whole purpose of sharing this model is to get that quick speed of pulling those symptoms out from your mind. So what do these 7 respiratory symptoms stand for? And I'll send these slides to Neelakshi and she'll send to all of you. Okay, so if you, I don't want you to think, oh, I have to take notes, but I think we're recording this as well. So very quickly, if you had 7 key respiratory symptoms, I'm going to bring them up on the slide here. If you ask each of these questions in the exam, you will not miss any respiratory diagnosis. I guarantee you this. And you will not miss cystic fibrosis, bronchiectasis, primary ciliary dyskinesia. You pick any respiratory diagnosis in the UK. But the point is, these may be negative question, negative history points, or positive. For example, if you ask the actor, or the examiner, okay, is there a history of cough? Yes. What is the character of it? So then you're moving next to 1, and then the 3rd and the 4th. I want you to practice this with somebody. I want you to really use this model and see, does this work for you? It may or may not work for you. Don't worry about it. If you've got a better model, please follow that. But the other thing about any symptom in medicine is how we explore that symptom. And my next slide is going to show you, the point of how do you probe a symptom? And I know, I appreciate this is not teaching medical students how to take a history, but I think history is one of the most poorly taught subjects in medical school. People just imagine or expect you to master history taking. But if you think about that question, what are the probes of a symptom? And let me just take cough, for example, and build up on this. I think if you want to become a top clinician, forget the exam. Just if you think about your pediatric career, if you want to be a top clinician, I think if you start doing this for every symptom that comes to you at the front door, you will be a super pediatrician. I can assure you of that. Why? Because you haven't left anything to chance. In the exam, you could argue with me, hang on, we don't have the time to go through all those 8 probes. Do the top 4. Onset, duration, character, or course, or severity. Let's take cough. How did it start? Was there a prodromal symptoms associated with it, or was it a sudden onset? If it was sudden onset, the differentials is going to be down to a foreign body. Duration, less than 14 days, more than 6 weeks. Acute versus chronic. What is happening to this cough? What is the character? Barking cough, chesty cough, early morning, worse at night, worse with play. You got your clues. You know what the diagnosis is going to be. How bad is it? Does it stop the child from play? Does it stop the child from sleeping? Does it stop the child from doing any activities? So if you were to use those 4 probes for any symptom, now put that for dysphagia, dyspepsia, you think of any symptom, you can put that very structured approach: onset, duration, course, character, severity. Practice it the next time, practice it tomorrow if you're in work, or the next week, and you see, you will get a sense of confidence of what you're dealing with. Yep. And I'm happy to answer any questions on that. But a model history-taking station, you see, could be something like this. Now, if you're starting off with respiratory, you've covered those 7 respiratory symptoms, you do a quick system screen, top to bottom, CNS, cardiovascular, GI, and then systemic episode or systemic symptoms. So if we were to stop here and say, hang on, what are we going through? What I'm telling you is my shortcut to success in a pediatric history station for the membership exam. Or the next time you see a respiratory patient in the assessment unit, try and challenge yourself with those 7 symptoms. So building on my formula of 7 respiratory, 4 cardiovascular, very quickly again, if you have a pen and paper, give yourself 5 to 10 seconds, think of 4 key cardiac symptoms. If you're feeling okay, you can put it in the chat section as well. Neelakshi is looking at me with the time. I promise, Neelakshi, I will not overrun, okay? 4 top cardiovascular symptoms that you want to explore in an exam. Who's feeling brave? Let me see if there's any answers in the chat. It's not a test. There's no right or wrong. You don't have to feel too worried. I will wait. I'll give you some time. Yeah, very good. So chest pain is your top one, isn't it? And you could argue again, hang on, why is he only talking about 4? I can tell you, you ask these 4 symptoms, you will get your cardiovascular diagnosis. And if you don't, I'm happy for this challenge, okay? And you can come out and say, hang on, you told us that you would. But actually, if you look at what those top 4 are, and the reason I'm saying these are my top 4 is the incidence and the appearance of stations here in the United Kingdom. So we can put hundreds of cardiovascular symptoms, but these are high yield questions. So of course, chest pain is a no-brainer in a cardiovascular station. You know how to build on it. Shortness of breath is slightly different in a cardiovascular scenario. So that's why you want to ask about, paroxysmal nocturnal dyspnea, exercise, what's happening to the child with activity. I find people forget to ask about edema in a cardiovascular station. If there is edema, the child is in failure. You know which way that station is going. So personally, I think it's a high yield question because presence or absence of edema. Palpitations. If the child is complaining to you about palpitations, is an adolescent, is a young child, you know which way the diagnosis is going to go. Again, your approach for these 4 symptoms is onset, duration, course, character, severity. Keep with that structured approach, you will not panic and you will keep flowing from one station to the other. So building up with our theme tonight, I'm going to ask you to think about 8 key gastrointestinal symptoms. And I know if we had time, we could stop here and ask and we can build upon that. But if you think about gastro, I want you to think very calmly and start from top to bottom, okay? I'm a pediatrician with a special interest in gastro, and I do this in my clinic all the time. I don't start primarily, if the child presents with abdominal pain, I'm not starting with abdominal pain. I'm starting in a top to bottom fashion. So now, what might those be? One of the biggest thing is to ask what's happening with the child's appetite. There's only one caveat to appetite, not in the exam, but in real life. If you have a toddler who's 18 months to 2 years, from then on, they learn the power of no, isn't it? So they torture their parents till they eat something and trade off. So they keep bartering things. Apart from that age group, any other child with lack of appetite is a red flag. But if you start from there, appetite, mouth ulcers, thinking about weight loss, I think it gives the station very quickly red flags and your penny drop questions. Now the food is going down. So think about dysphagia. Why I think this kind of a model is useful is you don't need to memorize this, isn't it? You just think, how is the food traveling down the GI tract? And you get that, the station becomes really easy. Features of dyspepsia. Now the food is going to hit the stomach. So vomiting, nausea. And as you go along, the biggie in the house, as I call it, abdominal pain, you all are masters of Socrates, and you'll get that history going. And then the food is digested, you're talking about bowels. Friends, can I tell you, if you follow this structure, there is no GI diagnosis that you're going to miss. Let it be inflammatory bowel disease, let it be celiac disease, let it be IBS. They're all here on the screen if you follow that structure. And then when you're talking about stools, remember, 4 questions are really high yield. Frequency, consistency, blood, mucus. Okay, so frequency, you've established what's normal for the child. Consistency is your Bristol stool chart, and then 2 red flags. If those are present, then you're going in a different direction. There is one sign in medicine which comes and presents as a gastrointestinal symptom. Again, for the paucity of time and rushing this forward, that is jaundice. If your patient tells you, doctor, my child is looking a bit yellow, or we notice after they were dehydrated and tired, they became increasingly yellow, you know what the diagnosis is. So jaundice, I think, is a good high yield symptom to rule out between differential diagnosis. And going forward, and I'll stop after the C9 and just open it up if you have any immediate questions, and then we will build it up again. One of the most difficult stations I find for trainees in membership exam is neurology. But again, neurology is mathematics. You ask the question, you get the answer, and you build it up in a logical fashion. So now neurology is complex. That's why it's got 9 in my formula. Because if either of those symptoms are, okay, you got the answer from the actor or the consultant in this case for the virtual exam, you know which way to go. So the way I think of neurology is to start thinking, headache, hearing problems, eye problems, speech problems. So if you go logically, I don't think you'll miss anything in the exam, but you got to practice, you got to rehearse this, and that's how it makes it easy. So in terms of children, fits, feints, funny turns are a big thing. Dizziness, if you don't ask about dizziness in a neurology scenario, I think you're missing out on absolute differentials, because that is a red flag till proven otherwise. We talked about eye changes, hearing problems. Now, sometimes you see, you've got to be smart and linking stations. Let me give you a quick example. If a child in a respiratory station has got clubbing and he's wearing hearing aids, so then you add 2 and 2, that has to be primary ciliary dyskinesia. So in a respiratory station, if they're saying they've got hearing aids, and this is how sometimes you got to think, and actually membership teaches you these things when you prepare for the exam. So we talked about the order of top to bottom. I think it works beautifully for neurology as well. Okay, so the thing about pandemic and what it has done is a lot of children with mental health issues easily brought into the membership exam scenarios. Expect a scenario with children's mental health in the membership exam is what I'm going to tell you. So you know that is the current big problem. If you don't have a structured way of approaching that station, I think you can sometimes not prepare for it. So please, can I urge you all to do that? So I've rushed through that because each of those could be a half an hour discussion in themselves. Forgive me for that. But again, now, if you are a chef, or if you are a very bad chef like me, okay, so you could cook a dish, you can take a history, okay, but you need that magical extra sauce to take it to the next level. Yeah, that comes with experience again, isn't it? So I struggle when I cook dishes like that. But I think when you take a history, you've done that history of presenting complaint. For you in the exam, I've got your special secret gold dust. You ask these 5 questions to every patient you or case you're discussing. Presence of weight loss, yes or no? Don't forget about skin and sleep in a pediatric virtual exam. I think sleep is becoming such a huge problem. Skin, systemic manifestations of any underlying conditions. The thing about energy levels, and this is a question for real life as well. If you ask a child, okay, well, how are your energy levels? If I ask each of you this evening, how are your energy levels? I'm going to get a 50-50 answer. The same with children. So rather than asking them, how are your energy levels? You're better off asking, what activities do you do in the week? And they rattle off karate, jujitsu, swimming, the energy levels are fine. But if they tell you, no, we've suspended all our activities, that is a red flag. So that is how you ask that question. The same question, if you say a child presents with abdominal pain and you ask them, does this pain wake you up at night? 50% of them are going to say yes. The better way of asking that question is, how are you sleeping? And if they say, yeah, I'm sleeping absolutely fine, that's a no-brainer, isn't it? Don't forget eyes and joints, because if there is an underlying condition that you haven't really grasped or picked up, if they say, yeah, they've got eye problems, they've got uveitis, they've got arthropathy, you can link it with a GI station or any other rheumatological diagnosis. So don't forget to ask these 5 questions in any station. And then in your HOPC, you're doing a quick system sweep. So that is your history of presenting complaint, compact, structured, slicing it with the best approach that you have in an exam and keeping it to time. And then the other parts of a pediatric history, you're all masters at it. You've done it time and again. But again, I want you to practice a structure, key questions. So you've done your history of presenting complaint, quick past medical history, any hospital admissions, surgical problems, any surgeries in the past. Yes, no, move on. With pregnancy, what I find is sometimes there's a lot of waffle. With pregnancy, you can absolutely master 5 questions: alcohol, smoking, and then remember SIM, scans, infections, medication. Medication, I think you all know about anti-epileptics and the importance of it in a pregnant mother, but don't forget antidepressants is my message to you tonight, because I think we are seeing a lot of children who can be affected if there's no counseling. You know this about birth history, but the thing is, don't lose focus on the time and structure. If you don't ask about meconium and the station is about constipation, then you missed an obvious clue, isn't it? In terms of Hirschsprung's or chronic constipation. So you need to remember 4 or 5, not just go off on a tangent and keep digging birth history into details that you don't need. Sometimes I feel people focus on ABGAS in a birth history. What is the yield of it if the child hasn't gone to SCABU or whatever, and then parents don't remember even in day-to-day life. Very quickly ask about growth and nutrition. How are things with the Red Book? Sorry, in Wales, we call it the Red Book. I don't know if it's changed in England. Apologies if it has. Growth and nutrition, you want to have a quick check. Now, development, you see, people get into an absolute knots here, because then they don't know whether to expand the development questions into each of those domains. It depends upon the station that you're doing. It's as simple as that. If you're taking a history station, which you've got, in terms of a problem, somebody with arthritis, somebody with inflammatory bowel disease, somebody with asthma, somebody with type 1 diabetes, use your common sense and see the importance of weightage of it. A very quick way of doing development and school is asking, does the child go to a mainstream school? You get so much from that single question. If the parent tells you, no, they've got one-on-one support, no, there is this support at school, you ask those 2 questions in the same way. I've got a twist for you about allergies. Most often when we think about medication, we're thinking about medication-related allergies. I want you to start practicing thinking about seasonal allergies, atopies, food allergies. If you ask that question, and if there is a positive answer to it, it could be a penny drop. And if it's a respiratory station, you haven't really pushed yourself to remember that point. You know the importance of that. and then you're wrapping it up. Now with heads, okay, please can I add another S, just in case you're wondering how on earth is he added one more. I think if you have an adolescent station or you're speaking to a 12 to 18-year-old, don't forget to ask about social media. I think it's really important that you ask that question. And if you do ask, you might have a penny drop with that, because that might be the revealing point of bullying or concerns. Please promise me you will never forget in a pediatric history taking station to ask about school. Please promise me, because there's something personal attached with this, because I failed my membership the first time. And I think I wish when I got the feedback, if I asked about school, I think I would have had lots of information about bullying at school. I did pass it the second time, okay? But I think actually it wasn't a bad experience to redo it, because I think I probably learned more. But please, please, please don't forget to ask about school. I think it's got huge importance. And if you ask it, I think you'll get lots of information. I've absolutely whizzed that through. I'm very mindful of that. I just wanted to share a model which I believe is high yield, will give you, a structure like you solving a history station with pure mathematics. And I think that give it a go, see if it works for you. I want to assure you, with the emendation that happens for the membership exam, there is no trickery. There is no trickery to catch out the trainees. There is no trickery to say, okay, we'll ask them that and we'll layer it with complexities. No, no, no. That is not the design of the membership exam. And sometimes, I have heard this from trainees who've given the virtual exam. They've been struck with the simplicity of the stations. Actually, the whole idea of membership is to see if you're at ST4 level and you're a safe doctor and you're a kind, compassionate, caring person. Isn't it? That's at the heart of pediatrics. So don't be surprised by the simplicity of the OSCE, and be prepared just to deliver all the key messages. And the structure for history taking will, please get a clear pass with history taking, because this is not complicated. This station is not complicated. If you stick to your script, let it be any problem with history or the long history that you have to take, you will be right on track and it shouldn't cause you any problems. I'll stop there and I'm happy to take any questions, or I'll be directed by the chair. Thank you.
Thank you, Dr. Pramod. I know we're really sorry that you had to whiz through this, and I wish we could have gone more. But to be honest, these points will help me whiz through all the queue of ED patients tomorrow. I think this was a big learning. I don't know about it for the others. It was a big learning for me, and especially, I think that's the whole purpose of the exam, is to make sure that you're a safe registrar working in a DGH. Because if I'm thinking through my ED shift yesterday, this is exactly what you have to do. You can't miss the main points, and you just whiz through the history taking so that you know what exactly to do. I think that was really helpful. Thank you. Has anyone got any questions? I'm just looking through the chat. No, I think Dr. Pramod, you're here with us for a while. So, and then of course in the communication scenarios, if you have any questions, please type on the chat or let us know, and then we'll be able to direct you so that you can have a chat with Dr. Pramod later on. And then I'm just going to hand over to my colleague Iman, one of the regional representatives of Team Soft Landing and an ST4 trainee in the KSS Deanery, to talk us through the rest of the evening. Iman.
Oh, thank you, Neela. Thank you, everyone, for being with us this evening. I'm delighted to introduce our next speaker. And our next speaker is Bola. She is pediatric ST5 trainee at West Yorkshire, and she is Yorkshire Soft Landing representative. Bola, she will talk to us in the next 10 minutes about tip tops for us as IMGs. Yes, Bola, it's over to you.
Hello, I just want to share my screen.
Yeah.
Okay. Have I done that right? Share.
We cannot see your screen, Bola.
Yeah, no, I'm trying to do that again. It's not. Sorry, bear with me. Get it up again. It didn't work. And just give me a minute. Okay, skip. Okay, it should work now. Share screen. And oh gosh, disappeared. What I wanted, sorry, bear with me. What I wanted to share just disappeared. Okay. Let's see if it works this time. Yeah.
Yeah, it's coming.
Yeah, fantastic. So, like I said, my name is Bola. I'm ST5 and I currently I'm working at Court J Royal Hospital. And I just want to share my top tips, my tips that I got from sitting the current method of the exam. I want to thank Dr. Pratt because Pram said almost everything I need to say. But I will reiterate one thing that he said, and that's the fact that I think particularly for any IMG, this is like your best chance of passing the exam because we are taught in different ways wherever we come from. You just need to say what you need to say and get the structure right. And like he said also towards the end, it is honestly, for me, the last exam I sat was like, by the time I walked out of the room I was sitting in, for me, it felt like, oh, just another day in the pediatric assessment unit. There was nothing out of the ordinary, nothing unusual. So my first top tip is take a deep breath. You've come this far, and if I could do it, then you can. It's just like you said, it's not, there's nothing out of the ordinary that you're going to come in contact with. It's going to be like another day in the pediatric assessment unit. So if you go into the exam with the mind that I can actually do this, I'm very unlikely to meet something I've never heard of. As long as you've been in this UK, you're going to make it through. So general things. And I'm saying this as an IMG to fellow IMGs, and I'm looking at what I needed. I think Pram has given us all the education practical things when it comes to the exams. I want to talk more about, I'm an IMG and I'm going to an exam that, for if you've worked in this UK, if you've worked in the UK for any length of time, you'll find that sometimes an F1 or an F2 that you're working with is probably a lot more fluent. And having worked with students, it's because that's the way they're trained. They're trained they understand the system, they understand all the structure, the practicalities and nuances of what to do in this kind of exam. And that's where I had a challenge. And I think that's where a lot of IMGs have challenges. So one thing I got told, and I think one thing that worked against me in one of the exam I did previously, was that I talked too fast. And I think somebody wasn't talking clearly. So be aware of how you speak. Ask people at work how you speak. I had my consultant, my supervisor, actually tell me that you do speak a bit fast and so you might not be clear. And this was because by the time I failed the exam twice, they had to sit down and say, okay, we need to go through this feedback and look for the loopholes. And one of the things was said, one of them was that I rushed a history. And so the role player didn't feel comfortable. And so, because they said, you communicate excellently, what's gone wrong? So ask people how you come across to them. Have somebody listen to you. Ask somebody who is a native British English speaker. Ask if they can understand what you're saying. Do you need to slow down? Do you need to speak louder? That's one thing. And then another thing, because it's a virtual exam, they're still going to consider your body language. If you go to the site, you have all the anchor statements. They still look at your body language. So you have to practice looking into the camera and making sure. So when I did my practice, I had another person doing the exam, and we're all in the same unit, but we did a lot of our practice sections on Zoom, just so we could get used to being on the camera. We could tell each other, this was where you came across on video. And so that's a very good way to practice. And I'm sure you've done a lot of practical work, and trust me, you can do this in the time you have before the exam. You can make those adjustments, because I did. And it also helps with fluency. So you get used to saying this thing, looking at the exam, not looking at sheets of paper, you're focused. And then practice describing for like the clinical exams. There are 2 clinical stations, and there's the extended clinical, there's the development station, and all these have to do with, you have a clinical exam of sorts. You have to get used to describing in a structured way. My first exam was a flop because I said I was very unstructured. I thought I was structured, but I wasn't. Fortunately, I had a colleague who was the queen of structure. And so she helped me with it. She gave me mnemonics. She gave me all sorts of things to improve my structure. And we did like 3 sessions. And by the time I was done, she said, you shouldn't have a problem with structure. And when I had the exam, it was like, your structure is excellent. That was the feedback. So those are things you can do. Have someone who's done this, maybe not even done the exam, but who's worked in this system, and who's a student who's schooled in this system. They understand the structure. A lot of F2s and F3s, because they've recently done OSCEs, they have loads and loads of mnemonics for neurological exam. My colleagues told me these were mnemonics they had from school. So that's one thing I'd like you to do. And then be familiar with the anchor statements and the score, because the scores are all based on these. For example, in a history station, like Pramis said, information gathering is very important, but I will tell you that every history station I've had, listening to the patient, the communication style had lots to do with it. My last history station was a patient whose daughter had anaphylaxis, and half of my history was taking the history, but half of it was about, she was able to tell me the worries that she had about it. And that was what the history station was more about, because the management, apart from the management, was what will I do to a lady's woman's fears? How will I manage her in the community? What can we do about that? And then 30 seconds were like, so if she came in the exam, if she came in the emergency, what will you do? So there was more to do with me listening to what her problems were than the actual clinical management of anaphylaxis, if that makes sense. Then communication stations, like I just mentioned, it's 5 out of 9 stations have something to do with communications in one way or the other. So I think it's like kind of great that we're doing this on communication, and the skills you take from these stations can be transferred to all these stations. You have communication in development, you're taking a history taking, there's communication, extended clinical communication. The 2, the 2 communication stations all have communication in them. And if you look at the anchor statements, you will see there's that session of communication, body language, putting patients at ease. They're there. So we need to, a lot of focus is on the communication station. I've mentioned listening to the history. And I've talked about information gathering and the communication style. And then in the communication stations, you need to listen more than you speak. It might be breaking bad news, but you need to know what that patient's problem is. What's their worry about the bad news? They might have their own ideas that they want you to deal with, and that's what you're going to be scored on, rather than actually telling them the bad news. And I've just put this slide in about breaking bad news, like ask the role player if they have someone they would want to be with them. That's important. You might find out that is what all this is going to be about. Oh, my husband's a soldier in the war. I don't know how I'm going to deal with this. And then a lot of your communication is going to have to really do with how you're going to help her, how you're going to support her, and things that you can put in place. Clarify what they know about the condition, and remember to pause. 5 seconds, 10 seconds, it's important. Explain the situation based on the scenario. So one thing that's really, really important is read your scenario. 4 minutes is a lot of time. It's a lot of time for you to plan what you're going to say. Like for the history stations, you can plan your entire, whatever the code Fran just gave us. It's enough time to plan all that. Plan how you're going to go about it. You're allowed sheets of paper in the virtual exam, so you can actually write down what you're saying, what you need to say, what you need to cover, just so that your ideas are there and you can actually glance at them. And then always remember to check their understanding in any communication. Check their understanding in any of the stations where you've spoken to the person. It's very important to check their understanding, and if it's appropriate, offer another meeting. for them so you can meet with them, and then always acknowledge your role players' feelings. The mother I had, for instance, with anaphylaxis, she was really worried about her child not wanting to go out because they never know what she's allergic to. She had multiple allergies. This birthday party she'd gone to, they'd taken everything. She was allergic to strawberries, I think it was. There were no strawberries, but then she tasted a bit of cake and came down with proper anaphylaxis. So, and that was like, they coached her, begged her, pleaded, and got her to that party. And so that was going to take her back out again, out of circulation. So it was a lot about how we can get her into what you can do to support her. So acknowledge their feelings. Mom was really worried about it. So acknowledge their feelings, and then signpost as necessary, websites. And that goes for anything, communication stations. I had one about circumcision. There were things I wasn't sure of, and I just said, well, I'm not sure about that, but I know the nurses that know all about this, and we can get the leaflets from them. And in my summary, I mentioned it. So, and this is what we said, this is what we said, this is what I said I'm not sure about, and we'll get to the nurses who always have a leaflet and can signpost you. And then practice for the clinical exams and all that. Please practice the structure of every system. Practice how you're going to go through it and be fluid. And then don't forget the scars. I got caught out on this. Always ask for scars, cardiac, respiratory in your examination, cardiac exams, respiratory exams, abdominal exams. Always ask the scars and be familiar where they're likely to be and what they're likely to be for. When you're checking for things like your apex beach, remember to check the left and the right side. Don't get caught out on a PCD case. There's lots of dextrocardia. And then in the developmental station, I think as you're getting there, just write down on a sheet of paper. Remember to do a general physical. Just remember, because you'd have taken your history and practically forgotten about it. Always do a quick general physical in the developmental station. I got caught out because of that. I didn't fail the station, but it was a comment that somebody said did not do a general physical. So please do that and ask about dysmorphic features as necessary. And like Pram said, because it's a virtual exam, you have to say everything you would do. For instance, I'll wash my hands, I'll look around the room, I will inspect for this, I'll introduce myself, make sure they're at ease. I will position the patient. If you have a patient that's for cardiac exam, for instance, I will position the patient at 45 degrees. You need to say exactly what you're doing, how you would do it as if you were doing it. So you need to say everything. It's really important. And then practice running through the examination with time to spare. I think the clinical exam is about 8 minutes, and I think you get about 5 or 6 minutes to do your examination and present your findings. Try and run through it fluidly with time to spare, so you have enough time to discuss your management, because if you miss out the management, you will miss out on points or scores. And then practice summarizing. It's something that the examiners always hammer on. Practice summarizing in 1 sentence, at most 2. This is what I've seen, this is what it is, and that's it. Because they've listened to you, so they don't really need the whole history again. Just, he's a 5-year-old boy, this is the salient things I found in the exam, and this is what, and they will ask you, what do you think, and allow them to ask questions. One of the things I'll say about the exam is that what I will really say about in the exams, particularly in the exams where you have to examine, you need to learn to pause. For instance, okay, I'm examining him and I'm listening to the heart sounds. You might want to say, what do the heart sounds sound like? Are there any murmurs? And they'll say, and I'll say, I'm listening to, like, one of the comments I had in my cardiac exam for this last exam was that I didn't listen to all the cardiac areas. In my mind, I had, but I apparently didn't say it. So I'm listening to the mitral area. What can I hear? I'm listening. You need to mention everything, otherwise you'll get caught out on it. I'm feeling for the liver. Can I feel the liver? And then if they say the liver is enlarged 5 centimeters, is it firm? Is it soft? Is it tender? You need to ask these questions, because that's them understanding that if you were doing this physically, this is what I'm checking for. And when you're checking, you need to say, I'm looking at the child's face, checking to make sure they're not in pain. Those are the kind of things. So I'm giving these examples as feedback I've got and things that I know that the examiners are going to be asking for. And that's about it, because I have spent more time than I have. So if there are any questions as we go on, please let us know and we'll get back to you.